live. I think I'm live. I don't know. Let me know if you're there. I'm in the Kinning Park Clinic. I'm just going to double check that I'm not talking to myself. Let me know if you're there and say hello. The plan tonight is to jump on and just talk about some of the cases that we've saw in clinic today. It has been, I think I'm live. There I am. I'm checking there. So I'm in the Kinning Park Clinic. You can probably see I'm in one of the clinic rooms just now. My name's Sarah Jane. I'm the clinical director here at the Rehab Hub, owner of the Rehab Hub, where we have Kinning Park and the West End, where we have clinics there as well, and also Pilates studios, reformer, fully equipped comprehensive Pilates studios, both Kinning Park and West End. Now, today I've been in clinic all day. I was teaching over in the West End this morning, did a little classic class, then come over here late morning and have been seeing patients all morning. We've had students in all day. So we had a fourth year student from William Wood. We always get lots of fabulous students coming in and doing their fourth year replacements with us. And then we also have sports therapy students from the City of Glasgow College. We always take some of them. So usually on a Monday we've got them in as well. And then we also take physiotherapy students, both masters and undergrads, and also podiatry students, undergrads for podiatry. So over here, so it's always a busy clinic. And today we've had loads in. So myself has been in, so I'm a musculoskeletal podiatrist as well as a Pilates teacher. We've got Ollie who's here as well, who's a musculoskeletal podiatrist. That means that we primarily deal with knee pain, hip pain, foot pain, pain usually. And we also have Mansi, who is our latest hire. Really fabulous to have Mansi. Mansi has joined us 6 years experience as a physiotherapist, and then she completed her master's recently as well at Glasgow Caledonian University. So really thrilled to have Mansi joining our team as a physiotherapist, and she's taken on the lead for all upper body stuff, which is fabulous. And we also have Lulu in today. Lulu is our sports therapist. She is a graduate of the City of Glasgow College Sports Therapy HND. Fantastic therapist, and is currently going through a Pilates teacher training just now as well. So busy clinic, loads going on. Now today I had some really interesting cases. It's always a bit, you come in here, it's busy. It's a busy clinic, man. I don't know if you can hear, there's loads of stuff going on just now out behind me. So there's classes and things running. It's a busy place. And today I've had it's always like this on a Monday. We've had Run 3D gait assessments, that's our infrared assessments. Ollie usually takes lead for all of them, and we had he's had 2 or 3 of them in today, I think. And somebody came in with knee pain, for example, and he came in and got his full movement assessment. So that looked at what his feet are doing, what his ankles are doing, what his knees are doing, what his hips are doing, what his back's doing, musculoskeletal assessment after that in here. And he's had an MRI before, and we commend shockwave therapy for him for patellar tendinopathy. So that's fantastic. He's on the road to recovery. He actually left today after his first treatment, feeling a lot better, less pain than when he came in. Also rehab programme from that. We also had today was a lady that came in who does a lot of high rocks, and she's in her 40s, and her right side at the side, I'll show you on the skeleton, side of her ankle, so the outside of her ankle, so the lateral ankle, really bad pain. Now I saw her last year with a similar presentation with the pain, but the pain last year wasn't as bad as it is this year. We got her sorted last year, she rested, did do the rehab, she's back in a year later. This time similar pain as in terms of the area. She's basically upped her running and she's training for a high rocks event, and she admitted herself that she's overdone it, as we do, don't we? I still think we're 21, but anyway, she's overdone it. And as a result, so what we did with that is, I don't know if you can see behind me, we scanned this. So we actually ultrasound scanned this to see what was going on. And what we found today was that her perineal brevis tendon, so this tendon here, running up here, at this kind of level, just above the malleoli, just here, just kind of as we're kind of coming into muscular structure, she had kind of thickness through the tendon. That kind of correlates with what she had last year. It's that kind of chronic thickness. And then down, just as that tendon's kind of coming down here, at this lateral malleolus, just as it's turning this corner, right there was a big batch of inflammation. We could see that with power Doppler on the ultrasound. So we could see that she had this tendinitis at this level. So actually more kind of chronic thickening of the tendon further up, but then this inflammatory process happening down here. Now that was really quite important because it then meant that we could give her the right treatment that she needed. So today she got laser therapy directly onto that lateral malleolus, calmed that down. We also put her on magnetotherapy, again tissue repair. We also commenced NSAIDs, so painkillers, ibuprofen, anti-inflammatories. So we were getting her sorted for all of that so that we can calm down this inflammation. And then we also did at that more proximal level, we're going to be commencing some shockwave therapy, but that will be next week once we've calmed down that inflammation. So that really the power of being able to get the diagnostic ultrasound over. So ultrasound, actually look chairside, what's actually going on, and from there get an accurate diagnosis. So that was another quite an interesting one today. I had a steroid injection review in, so a lady actually thanked my colleague Michael referred this patient over from AA Podiatry over in, I think, the south side, Clarkson area, AA Podiatry are. Now Michael and his team had been treating this particular patient for a suspected fracture, right, but she'd had an x-ray and it was inconclusive of a fracture. And so she had, I mean, the pain was really, really bad. She'd actually bought a boot and was wearing an offloader boot. And so Michael asked, could I refer her over and could you scan and see if there's tendon, bursa, what's going on? Because he tried everything and was getting nowhere. So brought her in for a diagnostic scan actually a week ago today. She's in the boot, active, fit lady, frustrated. We scanned, and what I could see, so it was basically the second metatarsal right here, right? And what I could see on ultrasound was this kind of almost reflective. So the bone generally will shine back brighter on ultrasound anyway, because the way that bone presents on ultrasound, it will be brighter because the speed of sound in bone is faster. So it basically shines back brighter when you're kind of looking at it on the screen. But this particular part, it did actually look like she'd had a hairline fracture. Now, it's no surprise that that wouldn't have shown up on her initial x-ray that she would have got, she said, back in September last year, because there wouldn't have been a clean break on x-ray. For a hairline fracture, you wouldn't pick that up, right away in an x-ray, because the x-ray will only pick it up after it started to heal, because it will basically show brighter on x-ray. So it's no surprise that would have been an inconclusive break, because it wouldn't have shown, if you're capturing my gist, because it wouldn't have been long enough to see the healing process on the bone if she'd have had it right away after she's had this injury. It was through running. So all made sense in terms of there was evidence that this bone had been repaired and it was brighter in that particular part, which would say this bone has been injured and a little stress fracture within that bone. So that made sense in terms of like the presentation, the history, the fact that we could see that there was still the kind of healing of that bone. Now it's healed now. However, at this point she still had grade 2 inflammation just at the joint. So it was really, really sore. She just couldn't get herself out of this boot. And even in the boot, it was really sore. So we decided last week that we would put a steroid injection into the actual joint itself, because when I was scanning this last Monday, basically the within the joint I can see inflammation. So what I could see was there was more than 50% of that joint was basically inflamed. So that would be, we class that as a grade 2. Grade 3 would be the worst. That's where, more than 50% is inflamed. That would be grade 3, and just sitting at more than 3 dots, so essentially up to 50%, would be a grade 2. So that's where she was. So fairly significant. No wonder it was sore. So we booked her in for Wednesday last week for a steroid injection, so into the joint, which we carried out on Wednesday. And today she was back in for a review appointment, and she can walk her in. So I'd said to her, rest, do nothing for the next few days. Over the weekend, I want you to start trying to weight bear in that. So wear the boot, take the boot off, weight bear, try and get her out this boot. So she came in today. Guess what she was wearing in her feet? Not her boot. Fantastic. She said for the first time in months, she's been able to get her feet into an actual trainer and not in a boot. So she's absolutely delighted. No pain. She said when she was in today, the only thing that kind of hurt, she bent down to get down into a wee mini fridge. Your toes will bend like this. And she said she felt a bit of pressure there. No surprise, it's still healing. She's not been in that position. It'll feel all stiff and tight. So she was delighted with that. Absolute joy to be able to do that, to give her that relief. And now what Ollie is working on her with, he gave her today some rehab to go away and do, so that because her foot's been offloaded for months, so there's weakness there. So we've given her mobility. Ollie's sent her off with mobility and strength work, so that she's building that all back up. And then we discharge that patient, and then she can go back and see Michael and his team at AA Podiatry. That's us kind of done our little bit. So that's something we do quite a lot. Steroids can work really, really well in the right circumstance, but because I was able to scan that and actually then know that that was the right thing to do, that gave us the knowledge that actually if we go in there with a steroid injection, then that would be the right thing to do. It's the right treatment. So getting that diagnosis is everything, isn't it? So you then know what you're doing. So those were just some of the cases that we saw today. There's been lots in today. It's been a really, really busy day, really interesting. It's another lady that we're helping, Nancy's been working on with some of her postural issues. So she's got kind of stuff going on mid-back, kind of T6, T7 area and thoracic spine. So Nancy did some work into that. I'm trying to think of other things that we've had in. It's just been one of those days, but those are the kind of ones that stand out with me. So we are the Rehab Hub. We are based over so I'm in Kinning Park now. This is our big facility, and we are a team of healthcare professionals. So we have physiotherapy, we have musculoskeletal podiatry, so specialist podiatry. We do all sorts of things from sports massage. We've got this Lulu, who's a sports massage therapist. She's got our sports therapy diploma. We've also got physiotherapy. We've got podiatry. Podiatry is not just about the feet, it's all the way right up to the pelvis. We do things like nail surgery, verruca treatments, we do fungal nails, all your usual podiatry stuff, corns, callus, all of that stuff. But we go beyond that, because one of the things that we are what we do is we look at why things are happening in the first place. So for example, that guy with his knee issues, a big part of and actually he was really interesting, a big part of, he's coming in, he's got his tendons, basically the front of his knee are sore, right, chronically sore. He's had that confirmed via MRI that he's got chronic tendinopathy, patella tendinopathy, and he's tried rehab. Now, he's telling us he's done his rehab well. It wasn't with us. I don't know if he has actually done what he was meant to do with whoever it was he's seen. But anyway, he said he's done his rehab, but we'll leave that there. But he'd never had shockwave therapy, never had anything specifically for tendons. And shockwave therapy is your NICE guidelines. It's your clinical gold standard for tendon problems. So he was coming in wanting an injection, and I was like, I'm not injecting that, no. What we're going to do with that is we're going to get you out of pain, we're going to start some shockwave therapy into this, and 2, we're going to get to the root cause of why you're getting this knee pain, not just why these tendons responding this way, not just deal with the symptom. And what transpired through his history was, as a kid, he had broken both ankles. Now, he didn't think this was significant, and it was only when I kind of looked at his kind of foot and ankle and went, why is your foot sitting like that? He says, oh yeah, I broke my ankles when I was 11. So very significant. And what I explained to him was, I was like, if we think about the knees, so I actually did use this pen, and I said, your hips are up here, your feet are down here, your knees lie in the middle. I was like, if I apply a force either end of this, what's going to break is the bit in the middle. The knees lie in the middle. So when you've got any dysfunction, either down at the foot and ankle or up at the pelvis or both, it will have an immediate impact directly onto the knees. So I kind of think the penny dropped for him at that point. He's like, oh, okay. We did further tests, musculoskeletal tests, and we found some imbalances. We found some weakness around the hips, and we found an unbelievable amount of stiffness and tightness around the foot and ankle, like a crazy, like genuinely a lot of work needing done there. And that makes sense. So when he's moving and he does high rocks as well, and he's getting frustrated. He's a young guy, he's only in his 30s. But what we do is we go that extra mile to make sure that we're not just treating the symptom, that we're actually going to help you get out of pain and stay out of pain, and know that your rehabilitation is specific to what you're needing. So he's he's got his shockwave therapy, he'll be in next week. He's got specific rehab, not just specifically targeted to his knees. That's going to be the end result, but actually he's doing a lot of ankle and foot mobility, because everything's kind of physics, where he's then loading and dumping into his knees. There'll be a lot of pelvic rehabilitation going on as well around that whole pelvis area, glutes, hip, lateral, all of it. But a big majority of his rehabilitation will be down at that foot and ankle as well. And that might be for him that, we will get this rehabbed as, to the best of our ability. Obviously he's broken both his ankles, so there will be only so much we can do, but we will take that as far as we can. And then there'll be other things that we might need to use. We might need to use orthotic therapy. We might need to, for example, right, so footwear has a massive impact. So we might need to really look at the structure and what he's wearing on his feet when he's at work, what he's doing, what he's wearing when he's training, because all of that will play its part in how he's loading his knees. So hopefully that kind of makes sense to anybody who's still with me listening to that. So that is just an example of what musculoskeletal health is, and the types of things, the types of cases that we see here. It really is, it's like problem solving and trying to get to the root cause of why you're in pain. So unless there's been like some trauma, something that's happened, that makes sense, that it's, if you're coming into me or any of my team and you've got a kind of unexplained pain, we're not going to just treat that. We're going to dig deep, and we're going to get to, let's find out, not only get you out of pain, but actually just make sure that we're dealing with the actual root cause of why you're in that in the first place. So, right, I'll sign off. If you are looking for an appointment with us, both West End and Kinning Park, you can phone the call centre. It's 0141 363 0306, or you can jump onto our website. It's just therehabhub.co.uk. And yeah, just you can book online 24/7, or just phone up the call centre, and the team in the call centre will help you. Sometimes you'll get through to Lulu, who's our sports therapist. If she's in, she'll sometimes go on the phone answering the phone, but the majority of the time we do use a call answering service to help us with the phone. We like to have the phone answered 100% of the time, so we're not missing calls. So the phone's definitely a good way to get booked in. Phone up 0141 363 0306 is the number, and either Lulu or the team in the call centre will help you with booking. Right, have a fabulous Monday. Hopefully you enjoyed my wee rant, and I will see you maybe later on this week.